Good morning, everyone. Welcome. Thanks for joining us today. I'm Doug Drysdale. I'm the CEO of Cybin. So excited to be presenting this phase 2 top-line safety and efficacy data. It represents a much-anticipated milestone for us, a goal that we've been working towards, and we're pleased to share with you the folks in the room today and also everyone that's joining on the webcast. Thank you for that. Before we get started, please review the cautionary statements on slide 3 of the presentation. So, as we described in our press release issued this morning, the data from our phase 2 study on CYB003, our deuterated psilocybin analog, is overwhelmingly positive. Our Chief Medical Officer, Dr. Amir Inamdar, over here, will walk you through the study design, the results that we are seeing, and also why we're so encouraged about the potential to offer much improved treatments now for patients in need. We'll then be joined by 2 world-renowned neuroscience experts. Joining us online, Dr. Maurizio Fava, who's the chair of the Department of Psychiatry and psychiatrist-in-chief for the Massachusetts General Hospital. He's executive director of the Clinical Trials Network and Institute at MGH, and associate dean for clinical and translational research at the Slater Family Professor of Psychiatry at Harvard Medical School. Dr. Fava is a world leader in the field of depression and clinical psychopharmacology. And we'll also be joined here in person by Dr. Gitte Knudsen, who's the chair of Neurobiology Research Unit at the Rigshospital Hospital and University of Copenhagen, and past president of the European College of Neuropsychopharmacology, and advisory board member, chair of the advisory board for the EU flagship project, the Human Brain Project. Dr. Knudsen is a world leader in neuropharmacology and molecular functional neuroimaging and leads investigator-initiated trials on psychedelics. So we're very excited to have them here with us today. And later in the program, we'll have an in-depth panel discussion and gain their insights on everything from what makes a rigorous study design to the limitations of standard of care treatments to their reflections on this new and exciting data. And finally, then we'll open up the floor to your questions here in the room. The findings you're going to hear about today are certainly significant for Cybin, but they're also significant in terms of progressing the whole mental health sector. Frankly, I see these results as the biggest breakthrough in psychiatric pharmacology in the last 40 years, and has the potential to transform the way we treat mental illness and improve patient outcomes. So let's get started. By way of background, for any of you who are new to the Cybin story, we are a clinical stage biopharmaceutical company with a mission to create safe and effective next-generation therapeutics to address the large and growing need for new and innovative treatment options for people who suffer from mental health conditions. We're applying deuteration to our key programs, optimizing the pharmacokinetics without adversely affecting the underlying pharmacology of these molecules, all with the goal of delivering fast onset of effects aimed at reducing in-clinic times, intermittent dosing versus chronic daily treatments as we see today, convenient dosage forms, and importantly, as you'll see here in the data, rapid and sustained therapeutic effects with positive safety and tolerability. In pursuit of this goal, we've assembled an expert team of drug developers who are supported by a network of world-class partners and internationally recognized scientists who share our goals. Our leadership team has a proven track record of bringing multiple drugs to market, having collectively managed more than 60 INDs with the FDA. We have the largest intellectual property portfolio in the psychedelic drug development sector, with over 38 patents granted and more than 172 patents pending. We also have the industry's most advanced and well-protected deuterated DMT program and 2 proprietary advanced clinical programs in development for depression and anxiety disorders, each now with proven safety and demonstrated safety and efficacy. This is a transformational time for us as a company. with a number of value-driving catalysts upcoming across our leading clinical programs. Today, we'll share with you our phase 2 top-line efficacy data for CYB003, and by year end, we expect to have phase 1 top-line safety dosing and PK/PD data for our deuterated DMT program, SPL028 and CYB004. Very exciting news to come there as well. We plan to initiate a multinational phase 3 trial of CYB003 in MDD and a phase 2 proof of concept study of deuterated DMT in generalized anxiety disorder, each beginning early in 2024. As I'm sure you're aware, the statistics around mental health conditions are simply staggering. To share just a few data points, almost 1 billion people globally suffer from a mental health disorder, with around 300 million people worldwide suffering from depression. Earlier this month, the CDC published a report noting that the suicide rate in the United States spiked in 2021, reversing 2 years of decline. And just a few days ago, I saw that 2022 was higher still. And unfortunately, about 30% of people with depression do not respond to traditional antidepressant treatments. And the suicide risk in those folks is 20 times higher for an individual with depression versus a patient without depression. And while SSRIs are the most common first-line pharmacologic treatment for depression, up to 2/3 of patients just don't respond. And in many cases, antidepressants have dose-limiting adverse effects, as we know, including weight gain, sexual dysfunction, and insomnia that increase the burden on the patient and on the healthcare system. To provide some context here, let's look at a range of data providing a cross-trial analysis. I know some of you have seen this chart before. It's not meant to be a head-to-head comparison, but rather it serves as an illustration of the current treatment landscape. If we look at 232 clinical studies of SSRIs since 1979, you see a mean reduction in depression score of less than 2 points versus placebo. If we look at more modern antidepressants that have been approved over the last decade or so, we certainly see an improvement over SSRIs, and we're showing here on this slide, slide 11, the best score improvements from pivotal studies of these treatments. But still, we're seeing maybe a mean change of about twice that we would see with SSRIs. When we look at the results of psychedelic studies, we see a 6.6-point improvement in a phase 2 study in treatment-resistant depression patients from COMP360, and impressively, a 7.4-point improvement in MADRS score versus placebo from our own SPL026 asset in MDD patients. You know, it's easy to see why there's so much excitement for the potential therapeutic benefits of these psychedelic molecules. And of course, the impressive 14-point improvement in depression score versus placebo with a single dose of 12 milligram CYB003 at 3 weeks that we shared just a few weeks ago. Our mission is to transform the treatment landscape by developing new, safe, and effective options with the potential to meaningfully address the current mental health crisis. I know that you're all eager to see the CYB003 results, but before we dive into that, I'd like to just quickly touch on our extensive DMT program, which includes impressive efficacy data in MDD from SPL026 and ongoing studies with CYB004 and SPL028. In a phase 2A MDD study, SPL026, which is native DMT, delivered rapid onset of effects with a 7.4-point reduction in the MADRS score at the 2-week primary endpoint. For those not familiar with the MADRS score, which we'll refer to frequently this morning, it stands for the Montgomery-Åsberg Depression Rating Scale and is a widely used clinician-rated measure of depression severity. To put that reduction into context, that 7.4-point reduction, that's about 4 times what we typically might expect to see from SSRI therapy. And impressively, these results were sustained. 40% of MDD patients were deemed to be in remission at 6 months, not 6 weeks, but 6 months, following 1 or 2 doses of SPL026. We also saw many patients still having benefits at a year and a year and a half. So providing tremendous proof of concept for the deuterated DMT program. When SPL026 is added to SSRI therapy, not only was the treatment well tolerated, but notably 92% of the SSRI group was in remission at 4 weeks after just a single dose. And as of course we've seen now with our CYB3 trial as well, avoiding the need to titrate patients off their existing treatments is a huge benefit, both for patients and for providers. These results are simply remarkable, and I think they go a long way to de-risk our deuterated DMT program. Today, as we follow up from the interim results we shared on November 1, we're showcasing the top-line phase 2 safety and efficacy data for CYB3 in MDD. In a word, the results are simply extraordinary. The phase 2 study was designed to evaluate safety and efficacy using the MADRS scale, and the primary efficacy endpoints were a reduction in depression symptoms and change from baseline in MADRS at week 3 after a single administration of CYB3 versus placebo. I'm thrilled to share that in addition to the rapid, robust, and statistically significant reduction in depression symptoms observed at 3 weeks, CYB3, we also have now seen a sustained improvement at day 42. So not only benefits at 3 weeks, but benefits at 6 weeks, and an impressive response and remission rate for those patients that received 2 doses. I'm going to hand this floor over to Amir, who's going to dig into the data in a bit more detail and share with you these impressive findings. Thanks, Amir.
Thank you, Doug. I'm delighted to be here today to share with you what can only be described as extraordinary top-line results from our phase 2 study. As Doug noted, the study we designed was to assess the safety and efficacy for CYB3 in MDD. This was a randomized double-blind design in adult patients who were aged 21 to 65 years in an ascending dose cohorts design. The intent for cohorts 1 to 3 was to assess PK's safety and identify a dose at which strong psychedelic effects could be seen. These were therefore small cohorts of up to 4 participants, with each receiving 2 administrations of the study drug. We started cohort 1 with MDD patients, but we pivoted to healthy volunteers for cohorts 2 and 3. Firstly, to speed up recruitment. And secondly, we realized that at the lower doses, these would not be therapeutic, so we did not want to expose MDD patients to a potentially subtherapeutic dose. Patients with MDD were at least moderately depressed. That was a score of at least 21 on the MADRS. And we enrolled inadequate responders, so patients that had failed to respond to their current antidepressant treatment, but were not treatment resistant. An important feature of our study design was that we allowed patients to remain on stable doses of their antidepressant medication. Within each MDD cohort, after a screening period lasting up to 4 weeks, participants were randomized to receive either an active drug or inactive placebo in a 9:3 ratio respectively. Once randomized at the dosing session, participants were administered the study drug. And during the program, participants were provided with psychological support by facilitators who were trained in our EMBARK protocol. After being discharged from the clinical unit, participants came back into the clinic to receive a second dose after 3 weeks. At this 3-week time point, we assessed the effect of a single dose of CYB3 on improving symptoms of depression using the MADRS. Now, we chose a regimen of 2 administrations 3 weeks apart, as we believed that a second dose would provide incremental benefit and would give us the best chance of demonstrating a robust and durable efficacy. Therefore, all participants who received including those who received placebo at baseline, received this active second dose after 3 weeks. And the same protocol as for the first dose was followed for the second dose also. A second assessment for any incremental efficacy was conducted 3 weeks after the second dose. We also have an optional period of assessment for 12 weeks after the final efficacy evaluation at week 6 to help determine the durability of treatment effects. This 12-week data will be available in first quarter 2024. On the next few slides, you'll see the top-line safety and efficacy data, but I want to highlight that we started seeing psychedelic effects at doses as low as 3 milligrams. Robust effects that are typically considered consistent with therapeutic efficacy were already evident at 8 milligrams. The onset of psychedelic effects was rapid, and noticeable effects were observed and reported at 15 minutes post-oral dose, with maximal or peak effects, which lasted for about 2 hours, with the majority of the participants reporting the maximum score on the visual analog scale, which was 100. On this slide, you will see that the populations enrolled across the 6 cohorts were comparable in terms of baseline characteristics. Most of them were in their 30s or 40s, fairly balanced in terms of male and females, and an average baseline MADRS score which placed them into a moderate to severely depressed category. This despite being on an antidepressant medication. Our safety and tolerability data also remains quite compelling, and the side effect profile was relatively benign. There were no serious adverse events. All adverse effects were mild to moderate in intensity, and all resolved without intervention. We have seen no evidence of increase in suicidality after treatment with CYB003, and only a few cases of nausea or vomiting, which were also observed in the placebo group. Any increases in heart rate or blood pressure were transient, and there were no effects on EKG or any laboratory parameter. On the next slide, you'll see the incredible results that Doug referred to earlier. On this graph, a downward direction of the lines indicates improvement in symptoms. Placebo is represented by the black line, and CYB003 is represented by the blue or teal-colored line. The vertical lines of black color represent standard deviation, which is representative of the sample size. As you can see, a single dose of 12 milligrams of CYB003 resulted in a rapid and large reduction in symptoms of depression. At the 3-week primary endpoint, CYB003 was better than placebo by 14 points, with a p-value of 0.0005. This translated into an effect size of 2.15, which you will appreciate is very large. Maximal effect or maximum improvement was already evident as early as 10 days, and this was sustained up to the 3-week time point. Similar large and robust effects were also seen with a single dose of 16 milligram, which resulted in an improvement in symptoms of depression, again as measured using the MADRS total score, by about 13 points when compared with placebo. These were evident earlier on day 1 with 16 milligrams and were also highly statistically significant. When data from 12 milligrams and 6 milligrams are pooled, these robust effects are maintained. At the 3-week time point, patients with MDD who received either a single dose of 12 milligrams or 16 milligrams had a significant improvement in their symptoms, with an average reduction of about 16 points on the MADRS, and this effect was highly statistically significant with a p-value of less than 0.0001. When we designed this study, our hypothesis was that a second dose of CYB003 will result in additional improvement in symptoms, and that it will ensure that treatment benefits are sustained for a long period of time. And while we await the results from a 12-week follow-up, the next couple of slides show the incremental benefit from a second dose. For both the 12 milligram and the 16 milligram doses, a second administration of CYB003 at 3 weeks, at that time point, not only was the initial response to a single dose sustained up to the 6-week time point, but it resulted in an incremental benefit over and above the effect seen at 3 weeks by up to 6 points on the MADRS total score. This is also evident when we measure response and remission rates. As you know, response is conventionally defined as a 50% improvement in symptoms, and remission is defined as a MADRS score of 10 or less. Typically, when you assess response with conventional treatments like SSRIs, you assess those in about 4 to 6 weeks. But what you can see with CYB003 is that a single dose, about 50% of the participants responded, and about 20% of the participants actually went into remission. And this was not only sustained, but it became even better at 6 weeks. At the day 42 assessment, more than 75% of the participants responded, and almost 80% went into remission at 12 milligrams. That is 8 out of 10 patients who were no longer depressed by 6 weeks, with just 2 administrations of CYB003 3 weeks apart. That's incredible when you put into context how long it takes for conventional treatments to see any sort of response in symptoms of depression. These sort of response and remission rates are really unheard of in MDD. And all of this with CYB003 as an adjunct to ongoing antidepressant treatments. These are truly incredible results for CYB003. And with the relatively benign side effect profile, they represent a unique opportunity to address the unmet needs in treatment for people suffering from depression. So to summarize, a single dose of CYB003 resulted in rapid and large improvements in the symptoms of depression. These improvements were highly statistically significant at week 3 and far superior in magnitude to what is typically seen with other antidepressants. Effects were evident as early as day 1 and reached statistical significance at 3 weeks. The improvement continued with a second dose of CYB003 with an additional 3 to 6 points after a second dose. This translated into response and remission rates that continued to rise after a second dose, reaching more than 75% at 6 weeks. When compared with existing treatments, these effects are far superior and translate into effect sizes that are greater than 2. In contrast with SSRIs, for example, which are the standard of care, and the effect size with SSRIs is traditionally about 10 times smaller. This is excellent efficacy, and this is accompanied by an excellent safety profile as well, with a limited number of mild to moderate self-limiting adverse effects. These robust data support progression of CYB003 into a phase 3 study, which we anticipate to begin in Q1 of 2024. I hope you find these results as compelling as we do. Now, let's hear from some of our renowned experts. Doug, I'll turn it back to you.
Okay, thank you, Amir. So, I mean, those results are truly outstanding and exciting, and we look forward to discussing those with the panel in a few moments. We're extremely excited about the CYB003 program to date, and with these remarkable results in hand, we're looking forward to preparing for a further investigation in a phase 3 trial. This is really truly significant progress that we've made, not only for Cybin, but also for the whole mental health sector, and ultimately for patients who are struggling and can benefit from a different treatment option. You know, it's worth noting again that both groups in our study, both the active and the placebo groups, remained on their SSRI treatments, meaning that the benefits of CYB003 are on top of those from SSRIs, which is a higher hurdle. And patients don't have to experience the challenging process of titrating off their existing treatments. You know, with this significant and sustained improvement in depressive symptoms we're clearly moving closer now to delivering on our mission to improve the treatment landscape across the spectrum of mental health disorders. CYB003 is now close to being a phase 3 ready asset, and we're highly focused on those next steps along the regulatory pathway. Our future plans include submission of this top-line data this year and requesting an end of phase 2 meeting with the agency to be held in early 2024. The goal of that meeting will be to align on the phase 3 trial design. And right now we are manufacturing GMP supplies that will be dose flexible, patient friendly, commercially scalable, and ready for recruitment of phase 3 patients around the end of the first quarter 2024. Other value drivers as we move into 24 include the initiation of a US phase 2 study in generalized anxiety disorder as part of our deuterated DMT program, and other formulation studies with CYB4 and SPL028 aimed at creating more convenient and less invasive dosage forms for those assets. So that concludes the remarks around the results for now, and we're going to move to some presentations from our experts before we get into a panel discussion. Let's keep going then with the program. We'll hand over to Dr. Fava to talk about the unmet needs with the current standards of care. Thank you.
Well, thank you so much. It's a pleasure to have the opportunity to speak this morning about the very promising results that Amir just showed you. I think I want to put a kind of a context for the importance of these results. You know, I had the opportunity to serve as one of the 3 principal investigators for the largest clinical trial ever conducted in depression called STAR-D. In the STAR-D trial, we treated everybody with an SSRI for 12 weeks. And with support, all kinds of things to help the patients. And the outcome was that only 1 in 3 patients remitted after 12 weeks. So if you think about it, 3 months of treatment and 1/3 of the patients remit. And half of those who remitted between weeks 6 and 12. So standard antidepressants, unfortunately, have the significant limitation of limited efficacy. So 1 in 3 patients remit, but also very slow onset of effect. So the efficacy takes time. You know, what we saw in Amir's presentation was a very, very rapid effect of a single administration, and remission rates with the 12 milligrams of 80% at 6 weeks. So you can contrast if you wish, because there was no randomization, but very, very promising results. The other limitation of the current monoamine-based therapies is related to tolerability. That is, you have to take these medicines every day. And they're not devoid of side effects. That is, approximately 20%, 15-20% of the patients will gain weight on SSRI or SNRI. 20-25 will have sleep disturbances. There will be 20-25% of the patients that have cognitive difficulties, problems with memory or executive function as a result of the treatment. And in addition, a significant proportion, 15-20%, may also experience a worsening of anxiety. So if you think about it, daily treatment for 3 months with an efficacy of a 33% remission rate and side effects that can be quite bothersome versus a model of care of single or maybe 2 administrations to obtain effects that are rapid and sustainable. So I think that, from my perspective, this is an important thing to keep in mind. The STAR-D level 2 we tested augmentation. Remember, in this trial, patients were augmented with CYB3. And in SAR-D, we augmented with bupropion and buspirone. And when you look at our New England Journal of Medicine paper on the outcome of augmentation, at 12 weeks, only 30% of the patients remitted at 12 weeks. And again, demonstrating how even when you look at augmentation strategies, such as bupropion augmentation of SSRIs, it takes a very long time. Because if you look at that curve in that paper, it's a curve that shows there's no steepness at all. That 30% remission rate at 12 weeks is achieved almost with a linear progression. So, that's the reality, if you wish, the context in which we have to look at the development of compounds such as CYB3, and the reality that only 1 in 3 patients will remit with the first antidepressant trial. So with that, I'd like to pass on to the next KOL.
Okay, thank you, Dr. Fava. We look forward to having you back for the panel in just a few minutes. With that, I'd like to hand over now to Dr. Knudsen, who will speak about the potential mechanisms for efficacy of psychedelic medications. Thank you.
Thank you so much, Doug, and thank you for inviting me to come here along and talk about my favorite topic, which is how these drugs do what they do. It's really remarkable, if you think about it, that just a single psychedelic dose of a compound can have such sustainable and long-acting effects. And I can't think of any other drug that has the same effect. But how does it work? That's what I'm trying to talk about and to give you some impression of what do we scientists think is a mode of mechanism. But first, a little about the nomenclature. We talk about hallucinogens, and often people refer to psychedelics very broadly, also including ketamine and NMDA and others that act in a different way. So today we'll be talking about the serotonergic psychedelics, which are the classic ones. And these psychedelics include LSD, psilocybin, and DMT, etc. And they all act by stimulating the brain's serotonin 2A receptors. And we know that for a fact, because if you block those receptors, there is no psychedelic experience. So this is a PET study that we have done in my lab, and shows the distribution of the serotonin 2A receptors. And the positron emission tomography is unprecedented in the way that it can show the target interaction and the blood-brain barrier permeability, etc., of drugs such as the psychedelics. And a few years ago, we undertook this study in healthy people where we PET scanned them before and after they were given different doses of psilocybin. And we looked at the association between how the brain's serotonin 2A receptors were occupied with the compound, and the dose that was given, and the plasma psilocin levels, the active metabolite of psilocybin, and also the subjective intensity rating. So we would be asking people while they were being scanned, so on a scale from 1 to 10, or from 0 to 10, what is the intensity of your experience right now? And here are the data we found, that when we measured plasma psilocin levels and brain receptor occupancy, we saw this very nice curve that was here composed of data from individual patients or individual people that were given different doses and scanned twice after the dose was given. And what we found was a very tight relationship between how much drug is in the blood and how much reaches the brain and affects those receptors. And moreover, we also were able to see a very nice relationship between the degree to which the drug was sitting on the receptor and the subjective intensity. And the last graph on the right shows the relationship between plasma psilocin concentrations in the blood and the intensity of the experience. Now, the question is, how do these psychedelics work? As I said, it's really remarkable that just one single dose can have such long-lasting effects. And there's been a lot of animal literature that has been trying to tease apart what kind of mode of actions are these. And firstly, and this is probably what many psychologists would posit, that these psychedelics, they induce mystical type of experiences such as feeling at unit with the universe, and time and space is rolling by in a different way. So they have all these experiences that are quite remarkable and different from what you experience otherwise. And it is believed that by this theory at least, that it's those experiences that can facilitate interaction with the therapist and will enable them to gain insight into their own disorder. So that's kind of a more psychological way of explaining it. But when we start to look more into the molecular mechanisms of these compounds, then, and here we can also see that the mystical experience that I was referring to before, this is how people describe the experience they just underwent. That means that if you take those experiences and you look at the long-term effects in healthy individuals, you can see that the measures of mystical experience that they have in these different subscales also reflects quite nicely how people perceive it in the long run. Now, another theory is that the psychedelics promote structural and functional neuroplasticity in the prefrontal cortex, that is the front part of the brain, which enable pathological circuits that are controlling our emotions, such as mood, fear, and reward, to be repaired. Now we are starting to look into rodent studies, and I'll get back to some human data at the end of my talk. But the idea here is really that you have sprouting of neurons. They make more contacts with each other. And at the left, you can see a nerve cell with the contact points called synapses, that they are interacting through these different modes of mechanism, the serotonin 2A receptor, the brain-derived neurotrophic factor, which is a factor that is known to be involved in the restitution of the brain and growth. And once you give psychedelics to rodents, you can see that they start to sprout and form new synapses with new neurons. So that's called neuroplasticity, which is really the brain's ability to generate new information and to have new ways of working, if you will. So another model that has been proposed is that they reopen the social reward learning critical period. What does that mean? Well, basically, if you think about a child, you will realize that children are much better at learning new things. And for instance, with language, if you don't talk another language at the age of 10, you're never going to be able to speak it as your mother tongue. So that's just one example of a critical window that you need to learn certain things at a certain age, and then after that period, the window is closed. The idea is here that by taking psychedelics, you can reopen that window and you can create a neuroplastic transformation that will enable you to get out of these rigid thoughts and iterative thinking like you see in mood disorders, where people often have thoughts that are circulating and ruminating around certain themes. This is data here showing at the left that you can see at the age of the rodents that at a certain age they start to decline. It's getting harder and harder for them to learn new things. But then if you give them psychedelics, in this case psilocybin, but it's also been shown with other psychedelics, then you will be able to kind of reopen that window. And this is another thing that is quite intriguing that we've seen here. And these different psychedelics, they seem to have different effects. And in this group, or this theory, it's been said that the duration of the psychedelic experience is also related to how long this window is open. Now, I just want to end up my talk by showing you some human data again, using positron emission tomography. It's possible to measure the amount of synapses in the brain. These are recent data that we showed for escitalopram, another antidepressant, SSRI. And what we can see in these healthy people is that when we treat them with SSRIs, in this case escitalopram, we can see that those who are on placebo, they don't change their synaptic density, but those who are treated with SSRIs, they have show an increase in their synaptic density. And we are currently having data acquired and analyzed, and I can see that it seems like we have also similar effects, but much more rapidly occurring with psilocybin. And with that, I'd like to end my talk.
Okay. Do you want to join us on the table? Great. Well, thank you, Dr. Anderson. So now we'll move to the panel. Do we have Dr. Fava on the line still? Great.
Yes, sir.
Okay. Okay, do we have these microphones working as well? Can you hear me? Great. Okay. Well, thank you, for that. I'm sure we'll have some more questions. Excuse me, some more questions around the mechanisms. But maybe we'll start with talking about study design. And maybe, Amir, I'm going to start with you. What are the key elements or characteristics of a well-designed study involving psychedelic drug candidates?
Yeah. I mean, the key elements probably don't change for a psychedelic. I would say the standard randomized double-blind placebo-controlled, which is a gold standard in the industry, which is what the FDA expect. That is also relevant for a psychedelic study. Now, of course, there are challenges with psychedelics, but they are not novel. And I'll maybe give some examples of why I think they are not novel. So key elements like a control group, blinding, using a good rating scale that is fit for purpose. But also for psychedelics, you have the added requirement of ensuring patient safety and provide. This is largely psychological safety, so you want some psychological support built in your clinical trials. And note that I'm saying psychological support. I'm not saying psychotherapy. I know that's an ongoing debate, and probably we won't be solving that here. But by giving psychedelics, you are opening up people's psyches, and you're probably destroying the defense mechanisms which were maladaptive. And even if those mechanisms were maladaptive and they were serving to continue their depressive symptoms or symptoms of mental health condition, they were still protecting the person. When you get rid of all of that, you need to provide some sort of psychological support. I call it psychological chaperoning more than therapy, because there's actually no therapy happening. But control groups, is placebo control still a good control group for studies with psychedelics? I would say yes, from a certain perspective. From a safety perspective, at least, a placebo group seems to be appropriate. Now, people question the utility of a placebo because with psychedelics they induce a non-ordinary state of consciousness. You immediately know who's getting a psychedelic and who is not. Having said that, we've observed that even patients with placebo, who are receiving placebo, they tend to get psychedelic effects, and sometimes it's difficult to say who is on active and who is on placebo. So I'd say that element of a traditional design is still relevant for studies with psychedelics. Blinding, absolutely. Is it possible to blind studies with psychedelics? It is. It's not. The problem of unmasking, knowing who's getting a psychedelic and who's not getting a psychedelic, that's not unique to psychedelics. It's not the first time in drug development that we are seeing it. I remember a long time ago when I was working as an investigator in a study of Risperdal, an antipsychotic used for schizophrenia. We immediately knew on the next day, who was on the active drug and who was on placebo or control group, because people getting risperidone would have strong extrapyramidal symptoms. They would start having tremors, they would have rigidity in their limbs, they would start drooling. So unmasking happens with other drugs as well. Sedatives, hypnotics. You give somebody sleep medication, it's quite obvious who's receiving sleep medication, who's not. So a placebo control is relevant there, and a placebo control is relevant for psychedelics as well. I think one challenge we've faced, and I think it's a key consideration for psychedelics, is understanding what rating scale to use, how to measure the effect of the psychedelics. Of course, the FDA have traditional rating scales like, for example, the MADRS or the Hamilton Depression Rating Scale or the Hamilton Anxiety Scale for measuring those symptoms. These are regulatory accepted instruments. But for a psychedelic, there are other effects that they induce which maybe are not captured by these traditional rating scales. I'm happy that Gita shared earlier the visual analog scale, which, by the way, I love. I think it's a simple and a very efficient scale of measuring who's actually getting the full effect of a psychedelic. And some of the data you showed earlier with respect to psilocin receptor occupancy and correlations with the visual analog scale, we've used those data in our dose escalation to identify doses at which we felt it was okay now to move into patients with MDD. So those are some of the critical elements, I would say.
Yeah, thank you for that. It's fascinating to me that we see placebo patients scoring high on the visual analog scale.
Yeah.
So to me, that says the placebo is doing its job and is working. So okay, next I'll move over to Dr. Fava. Dr. Fava, are there best practices or specific methodologies that you believe would be most promising for advancing the understanding and development of psychedelics for treating mental health disorders?
Thank you. It's a great question. I think that the same methodologies that were applied to the trial that Amir reported are going to be critical. So, for example, in this trial, we ensured that patients, the quality of the patients was really excellent because had an independent verification, and the patients had the diagnosis, the severity, the treatment history required through what we call a safer interview. And that methodology has been shown over and over again to the risk trials in phase 3 where you're making sure that the right patients get into the trial. So in my mind, this is an important addition to all the other methodologies that Amir has outlined.
Yeah, I think that safer tool has been very helpful, and I assume we'll continue to use that going forward. Dr. Knudsen, and maybe coming back to your presentation, what are the key differences between how psychedelic drug candidates work versus the current standard of care like SSRIs? I mean, what could be the underlying mechanisms that you think?
Well, first of all, I think the SSRIs take longer to work. We know that it can take weeks before they work. We even, for those compounds that have been in use for more than, 50 years or so, we're not really certain about the mode of action. It's generally believed that they work by increasing serotonin levels, but they certainly also increase neuroplasticity. And I just showed you some data that supports that notion. But what is really striking about the psychedelics is the rapid onset and the persisting effects after just a single dose. That is very striking and very different.
Thank you. So, Dr. Fava, maybe as you think about the current treatment landscape, what are you think the most pressing issues or the most pressing challenges, the greatest unmet needs when it comes to treating depression and anxiety today?
Well, that's a great question. I think that in my mind, the modest efficacy of standard therapies is a big issue because imagine if you went to the doctor said, look, I'm going to give you this antibiotic. It will take 12 weeks to work, and you have a 33% chance of actually remitting. I think you would be very unhappy with that. The modest efficacy of standard therapies is an issue. The fact that, you have to take them every day and they have side effects leads to poor adherence to treatment, people not taking them and then having relapses and recurrences, even when they do work, are the main issues in my mind.
So would you say, Dr. Fava, that CYB3, based on the results we're seeing so far, has the potential to address some of those unmet needs, some of the challenges?
Yeah, certainly the remission rate is big, 80% is far different than the 33% chance of citalopram in level 1 of study.
Great, thank you. One for you, Amir. So coming back to study design a bit, can you go over again why you chose to administer 2 doses of CYB3 rather than just a single dose?
Yeah, that's an interesting one as well, and we debated quite a bit because traditionally there's been this concept of one and done in the field. Realistically, one cannot expect a patient to receive a single dose of a drug and be done with it. People, by nature, things like conditions like depression are relapsing and remitting illnesses. So to expect that one treatment will cure patient of their condition is honestly is being a bit stupid.
That's definitely ambitious.
Yeah. Well, we evaluated quite carefully what should be the dosing regimen. We looked at the literature. We looked at some of the published data with psilocybin in this area. And what we saw was in some large, well-controlled studies, you start seeing the effect sort of wane off around 4 to 6 weeks. And we wanted to preempt that decline in the benefit that was achieved after a single dose. So 3 weeks, we said 2 doses 3 weeks apart would ensure that there is an incremental benefit of a second dose, and that would ensure sustained efficacy. Our goal was to sustain efficacy for at least 6 months. Of course, we'll in this study we'll evaluate up to 3 months. In our pivotal studies, we are going to look at 6 months for durability. But that second dose was essentially to, 1, ensure there is durability of effect, and 2, we also thought that some people need a bit of time to do the psychological work that will result in improvement in their symptoms. And maybe if they don't do it at the first treatment session, they could do it at the second one. And then we looked at some of the data with other drugs which have a similar mechanism of action. So, for example, things like ketamine. Ketamine is not a psychedelic, but the downstream effects of ketamine are similar to the 5-HT2A downstream effects from a biological point of view. And you see about 4 weeks, that treatment regimen seems to work for ketamine. So in the absence of any other published, very clear data, we made certain assumptions, and clearly they paid off, because you see with a second dose, there is an incremental benefit and there is a robust improvement in response rates.
I agree. It's clear from those results that that second dose really improved both response and remission, which is the ultimate goal. Regardless of score changes, It's getting patients into remission is what matters. So we're talking about improvements in depression symptoms here, but Dr. Knudsen, do you think beyond depression that there are other indications where psychedelics could have potential therapeutic benefit?
Well, yes, I'm a neurologist, so of course I've been thinking about what can we do for those patients as well. And I think there's a number of indications that are very interesting for the purpose of testing psychedelics. We have conducted a small-scale study in patients with chronic cluster headache, which, if you know about that, that's one of the worst type of headache you can have. And some patients even have a more chronic version of that. It usually comes in attacks. And anecdotally, people have talked about psychedelics as something that would have been reported to help. So we looked at that, and we actually saw that these patients also benefited from this. I think there are a number of other pain conditions where it could be really interesting also to look into this. But apart from that, conditions such as anorexia, OCD, obsessive-compulsive disorder, anxiety, and so on. So I think there are many different disorders where it's worthwhile to try to look into the efficacy of these promising compounds.
Yeah, it's unusual for molecules to have such broad application, isn't it? One again for you, Amir. I'm just thinking about translating these results, this effect size, into phase 3. What are the challenges? What are your expectations?
Yeah, I mean, the setup we have for a psychedelic study is different, and yet not too different. And it's similar for example, some of the biologics where people have to come in and spend an entire day, similar to ketamine administration clinics. But as we go into bigger studies, large multicentric clinical trials, multinational clinical trials, there's bound to be increases in variability of the data. I certainly don't expect the effect to be as huge as we see in this small study. But I'm not worried, because there's plenty of room. Even if you get half of the effect that you see in this study, even if you get half of it in our phase 3 study, that will be at least 3 to 4 times more than traditional treatments. So I think with the variability, with the number of centers that we will have in our phase 3, we will expect to see some reduction in effect size, but definitely still be better than SSRIs and other antidepressants. The other challenge is to manage expectations. I think at a larger scale, we've trained the small group of sites. We had to manage expectations with patients. With expectations, you see placebo effects, and with placebo effects, you start losing the difference. Mm-hmm. Many a study have failed because of huge placebo effects. What we are going to try and do, and we've started working on this already, is to try and minimize the contact between the patient and the clinic, so as to reduce the placebo response. Most of the assessments we are going to do remotely. Some of the psychological support work we've already piloted in this study that we completed, which we are going to implement in our phase 3, where most of the psychological support will be done remotely, so patients don't really need to come to the clinic. It also makes sense because if many patients are put off by the number of visits, by the number of assessments that typically they have to do, and if you allow them to be in the comfort of their home and still do the work, they will do it. Just like us, I'd prefer to work from home and not really commute to office like 3 hours a day. It's the same for patients. So we are addressing some of those challenges, hopefully we will see similarly robust effect sizes in our phase 3 studies.
It sounds to me like the fundamentals, so robust study design, very good screening processes,
absolutely,
and then site selection, sites that are motivated and continue to recruit.
Yeah, I mean that is your investigator or your site is the single most important factor in the success of a study, and you need people who are, as you said, motivated, who understand the studies or what to expect from a psychedelic study. Because for somebody who's not seen a patient undergoing a psychedelic effect, it can be a bit challenging to handle some of the symptoms. As I said, they induce non-ordinary states of consciousness, which can sometimes put people off.
Yeah. Okay. So moving then maybe from study challenges to challenges of adoption. Dr. Fava, from your perspective, what are the hurdles that we face as developers with providers in terms of getting adoption of these treatments into their protocols?
Well, I think that there's going to be a challenge for all healthcare systems to think through how to deliver these treatments, because in some ways the current setting may not be suitable to deliver the care. So we need in some ways specialized settings, but I see it as an opportunity to really rethink how we deliver care, and so it's a challenge, but it's an opportunity. But we have to start thinking about it, because we don't want to get these treatments approved and then say, now what? We want to be able to start thinking already how we integrate them, how what spaces we adopt for the delivery of care, how we organize it, and so forth.
Yeah, I agree, and we've learned a lot from our study. The study rooms, the treatment rooms that we've been using are quite simple. They're comfortable spaces, beds, sofas, lots of pillows, blankets. Patients are wearing an eye mask and wearing a headset. These aren't complex clinical spaces, and also with a simple dosage form like a capsule or a small volume injectable. No real specialist clinical setting is needed. So that we thought about some of those things. I think that definitely helps with adoption, we hope.
Yeah. But also we see in medicine that when there is a groundbreaking treatment, the healthcare system evolves and adapts. We've seen this with ketamine. The infrastructure for delivery of ketamine was not there before, but it evolved and the system adapted, and now it's commonplace for people to go to a ketamine clinic and get the treatment. And the same thing will happen with psychedelics. Once they are approved and once people see the profound effects they have and the changes they can make to people's lives, then the healthcare system will adopt.
Yeah, and we're already seeing that to some extent with Spravato, I think, and it's really taking off now, and it doesn't have the most convenient dosing regimen at all, and that's still getting a lot of traction. So I know we're about out of time for this part before we hand over to questions, but maybe one last question for Dr. Fava and Dr. Knudsen. When you look at this data, we obviously find it very compelling and exciting. What do you find compelling about the data?
Well, I think what I found most compelling is, I mean, you have a large effect size, obviously, but I thought that what I found really compelling was the fact that you saw these large effects also in patients that were on existing SSRI treatment, which I think is great news. There was a big concern within among researchers that this would be a problematic thing, that you would need to taper SSRIs before starting psychedelic treatments. But I think it also opens up for the possibility that you can add psychedelic therapy on top of existing SSRIs when people do not have a sufficient response, and you can still have a very, very good response. So I found that very compelling. It was great that you allowed for that.
Thank you. And last, then over to you, Dr. Fava, for any final comments.
Yeah, no, I agree. I think that fundamentally, these were patients that had over 30, a score of 30, or more than 30 on average on the MADRS. So these were significantly depressed patients who had a remarkable improvement. So that was really impressive.
Thank you. Thank you to all of our panelists. Now, we're just towards the end of the session, just going to hand over to questions from the floor. We have a couple of microphones if anybody has a question.
Hi, good morning. Good morning. Patrick Trucchio at H.C. Wainwright. A couple of questions. I think first, for Dr. Fava, I wanted to revisit some of the comments earlier. I wanted to get a sense from you how you envision psychedelics being administered in the real-world setting, specifically with CYB003, based on the data you've seen so far. If this data is reconfirmed in phase 3, what proportion of patients with moderate to severe MDD would you envision CYB003 ultimately being appropriate for and being prescribed for?
Well, that's a great question. I think that if in phase 3 the results are confirmed and we have a very robust efficacy, but efficacy accompanied by a repeated response with a single or two administrations, this will change dramatically our paradigm. So normally, let's say, you come into our depression clinic, you get started on the medicine, let's say an SSRI, SNRI, you're seen maybe 2 weeks, 3 weeks later, you continue the treatment, and then you see. And then you continue, if you wish, often, particularly if you have had prior episodes, you may be on that medicine indefinitely or for very long periods of time with frequent, relatively frequent visits to monitor both side effects and efficacy. If the sustainability of these treatments is very long, how often people would be followed up would be, may differ drastically from the current treatments. So patients may need to come in once or twice to receive the treatment, and then that monitoring of tolerability, side effects, and efficacy. The tolerability is no longer the issue. They're no longer on a medicine. So I think that we'll, as a field, we'll have to think, how are we going to deliver agents like this? And I really think it's an opportunity, because right now, part of the fact that access to care is so challenging. We have a shortage in the United States of over 14,000 psychiatrists and over 50,000 psychologists, according to the government. So, with a shortage of providers of that size, it partly derives from the modesty of the efficacy of the treatments, and the fact that they require frequent, visits. If we change how we deliver care, and we have much greater efficacy, hopefully we'll be able to provide much greater access to patients.
Yeah, that's helpful. And then maybe a few for the company. Just the first is, I understand the patient data remains blinded, but I'm wondering if you can give us a sense of if the improvements on the 12 milligram cohort with one dose, were those at the second dose, were those across all patients, or were there some patients who were maybe not responders who then became responders? How do we think about that incremental benefit from the second dose?
Yeah, maybe I'll take that one. And actually, I'd like to know the same. As you said, the data is still blinded, so we haven't gone into a patient-level detail. What I can say is, summary data, it's quite clear. A second dose, there is about 3 to 6 points improvement on the MADRS. And 3 to 6 points, when you compare that with SSRIs is about 2 points. It's at least 2 to 3 times more. So we definitely see an incremental benefit of a second dose. Are there specific patients who do better than others? Are there some who do not have a benefit of a second dose? It's probably likely, but we have to dig deeper into patient-level data for that.
Got it. And then just what do you think is necessary to be demonstrated at 12 weeks from a regulatory, though also from a payer and patient perspective?
I think if we see sustained responses, not traditionally with antidepressants, you see 50% or less response rates. If even we see half of the patients maintaining a response up to 12 weeks, I think that will be robust data, and that would be acceptable.
Maybe one last one, just if you can discuss the therapy component or psychological support component.
Yeah.
How do you kind of suss out the impact of the therapy? The placebo was actually the SSRI, and so how do we kind of think about that, and how will that kind of go forward? What learnings emerge that you can then get to phase 3?
So firstly, I'd say we did not do therapy. We did psychological support. I'm very careful about saying what we did, because when a patient is receiving or experiencing a psychedelic effect, they are in the clinic, no therapy is possible. All you do is hand-holding. You give them some reassurance. If they become anxious, you remind them of some techniques that you would have discussed with them previously. We follow the standard paradigm, which is prepare. Then during the session, you sit with them and ensure their safety, and then follow up you debrief, which is actually not very different from what you do in clinical practice. If I am prescribing somebody an antipsychotic, before I prescribe them that medication, I tell them what to expect, what will happen with the drug, how to manage those effects. And once they've taken the medication, they come back for a follow-up. We debrief. We say, how did you do? What could you do better? So what we've done with our psychological support model, which is Embark, and this Embark was developed after a very careful review of what was existing out there in the community and the varied practices for psychological support with psychedelic therapy. We follow a preparation up session which can be done remotely. That's one of the efficiencies we've developed in the trial, that this can be done remotely. The only time that a patient needs to be with the therapist is when they are receiving the drug. So that reduces the resource burden. Even the follow-up or integration sessions, as they are traditionally called, they can be done remotely. And we are going to carry this forward in our phase 3 as well. We have worked with an external partner called Fluence to to adapt or rather evolve the EMBARK psychotherapy model into what we call as EMBARK CT or EMBARK for clinical trials. It's necessary to differentiate between what is ideal for clinical practice and what is appropriate for a clinical trial. So we've taken that EMBARK model and we have evolved it into something that is more scalable, can be deployed very easily, and does not place an undue burden on the resources at the site, which is what we are going to use in our phase 3.
Helpful. Thank you very much.
Sumant Kulkarni from Canaccord. Thanks for hosting this event. First one for Dr. Knudsen. You've done some really interesting work on receptor occupancy and PET studies. With that as a backdrop, what do you think the potential is for buildup of tolerance or tachyphylaxis for these psychedelic molecules?
What is the potential for?
For tolerance buildup.
Tolerance. Oh, yes. We've done also some longitudinal studies, PET studies, where we've looked at the downregulation. So expectation is that if you stimulate a receptor, you will downregulate. And we've actually seen some of our data have indicated that the degree to which the 5-HT2A receptor downregulates is associated with the long-term beneficial effects in mindfulness in healthy individuals. So it seems to be actually a good thing that you have some sort of downregulation, but it's very minor. It's not a major downregulation we see. And my guess is that with such a brief exposure, then after, say, 6 weeks, I think you'll be back to normal. But that is, of course, something that can be investigated. But I'm not expecting to see any major downregulation or tolerability.
And then for the company, a couple of questions. How do you explain what you saw on the 12 mg and the 16 mg in terms of the scales? Is it simply a statistical quirk because there were too few patients in this trial? Or could it be something else like the differences in background medication that people on 12 mg versus 16 mg were?
Yeah, so you probably answered yourself, Suman, there. We had about 24 on 12 milligrams and 12 on 16. So it's maybe a statistical quirk, but it will be, as Patrick mentioned earlier, it will be actually interesting to go down to patient level and see what background SSRIs or SNRIs those patients were on and whether that modulated their response to treatment. What I can say is 16 milligrams is quite an intense experience. 12 milligrams is intense, but is the preferred dose, which is what we are planning to take into our phase 3.
And as you go to the FDA next, interactions with the FDA, what are some of the, places where you think there could be pushback from the agency given what you've seen in terms of your trial design? Is there any potential for the FDA coming back and saying, this is something you need to do differently?
Yeah, so one thing that we will do differently is we will keep the placebo arm as a pure placebo arm. So right now we have the placebo group receiving placebo at day 1 or baseline and then switching to active at week 3. That is not something we will do in our phase 3. Which actually aligns very well with what the FDA have recommended in their draft guidance on psychedelics. So we anticipate no pushback because as of now, our clinical plan for phase 3 aligns perfectly with what the FDA have suggested.
This is Elaine on for Charles Duncan at Cantor Fitzgerald. As you've shown earlier, COMP360 achieved a placebo-adjusted difference in MATTR score of about 7 points, whereas CYB003 showed 14 points. Would you attribute this to patient selection, like MDD versus TRD, the implementation of a second dose, or differentiated PK profile or bioavailability?
So maybe I can make a few comments on that. Obviously, patient population is different between COMP360 and CYB3. COMP360 was studied in treatment-resistant depression patients. At the beginning of the program, we made that decision not to pursue treatment-resistant depression. That's, to me, is a different type of depression. Maybe Dr. Fava has different views about it. But certainly, the fact that we started with inadequate responders, these were not first episode depression patients. They were patients who were already on an antidepressant medication. Despite that, they had scores of, on an average, 30, 33, which is moderately severe depression. That's one key aspect. And again, the strategic decision we took in the beginning to administer 2 doses rather than 1 to give patients the best chance of improving, that is probably a differentiating factor as well.
Yeah, I can just add to that. I think obviously the 14-point reduction was at a single dose, of course, but preclinically with the deuterated compound compared to non-deuterated compound, we did see an increase in bioavailability, and we saw an increase in brain concentration ratio, brain to plasma. So it was clear to us that more of the molecule was getting into the brain and out of the periphery. We also, of course, saw robust psychedelic effects at 8 milligrams. And we pushed the dose all the way up to 12 and 16. So it may just be that we pushed the dose higher and we've got more of it getting into the brain. It's hard to tell at this point exactly which of those elements is playing into it, but it's something along those lines. One for Elmer over here.
Hi, Elamir Pirosh from Stockbox Securities for Dr. Fava. Dr. Fava, you mentioned that in the STAR-D trial, you've seen a 30% remission rate. When you look at the package insert of recently approved antidepressants, they don't talk about remission rates. Why do you think that is?
That's a good question. Because it's a higher bar. It is, the response is easier to achieve than remission. Think about for example, in the CYB3 trial, patients had an average of 33 on the MADRS. To get to 10 or less, you need to go down by 20, 25 points, and that's much harder than a response which is a 50% reduction. So from 30, you achieve response by decreasing the score by 15 points. So in general, I would say most package inserts don't really focus on remission, which is the ultimate goal of treatment, but focus more on response because, it's of course a easier clinical outcome to achieve.
Right. So what do you see as a key difference between clinical trials that examine the daily pill regimen, like Trintellix or Auvelity, versus a psychedelic clinical trial when we compare drug effect to placebo? The placebo effect in conventional trials seems to be much higher. Why do you think that might be?
Well, this is something kind of a new territory, right? Because, one thing that we know from trials of standard antidepressants is that the placebo response tends to occur in the first half of the trial, regardless of its duration. Most of it, like 80% of the improvement of placebo, is in the first half. So if you do a 6-week trial, most of the improvement it's in the first 3 weeks. But that also based on the fact that you take a medicine every day. So you have to think about you doing something every day to get better. So taking the pill twice in 6 weeks, a placebo pill, may have a different effect. That is, you may not have the same level of improvement. And so that's something that we need to understand. That said, we have seen robust improvements with placebo, even with intermittent dosing, like in the case of esketamine. So you can never underestimate placebo because you always want to make sure that you're trying to minimize. But thus far, I think that the daily placebo has a more predictable, robust improvement than intermittent.
Thank you. Thank you very much.
Okay. Hi. Matt Venezia here for Jim Malloy at AGP. I just had a question for the company. First of all, congratulations on the clinical trial readout. I just wanted to dig more into that 6-week endpoint, and I know in the control versus the placebo group, you guys gave a dose of CYB3 to the placebo group at the 3-week mark, and then I just wanted to know how that affected the placebo group by the 6-week endpoint, and I wanted to confirm my assumption that you couldn't compare the placebo group to the active group anymore because you gave them a dose of CYB3.
Yeah, so at 3 weeks, it essentially becomes an open label. And what you are looking at 6 weeks is in those patients who received an active dose at baseline, what is the effect of a second dose? Does it improve the response, which we obviously saw? There's an incremental benefit of a second dose. What we also did was look at the patients who received placebo at baseline and an active at week 3, and that was by design. We planned to use placebo patients as their own control, and when we do that, between week 3 and week 6, there's roughly about a 14-point improvement in patients who were assigned placebo at baseline. So I say this to folks in the company that one dose of CYB3 is worth about 14 points on the MADRS. So that's the improvement we saw.
Okay, got it. And then I just had another question about the SSRIs. So you guys have the SPL-026 trial where you had some patients with SSRIs and then a few didn't have SSRIs. And you saw a much greater improvement as well as like durability of remission in the SSRI group versus the non-SSRI group. And are you going to take this into account for your phase 3 trial design? And do you expect to see similar results when the patient data from CYB3 gets unblinded from the phase 2?
Yeah, I mean, everybody in the CYB3 study was either on an SSRI or an SNRI. The SPL-026 came as a surprise to us. I think that was the question that Dr. Knudsen was alluding to earlier in the industry or in the sector, that do SSRIs blunt the response of psychedelics? Is there any interaction between a psychedelic and SSRI? That was the main reason that study was done, and we also looked at efficacy, and we were quite pleasantly surprised to see such a robust response for SPL-026 on top of SSRIs. When we dig into patient-level data, we will obviously, for CYB3, separate them into SSRIs and SNRIs by drug class and see if there's any difference. And we plan to do the same for phase 3. In phase 3, we will allow patients to remain on stable doses of their antidepressant medications. There will, of course, be some exclusions like monoamine oxidase inhibitors. We don't want that. But otherwise, they'll stay on their treatment. It just doesn't make sense to take people off their drugs, off their medication. The discontinuation syndrome with SSRIs probably may dampen or reduce some of the benefits we see. So we don't want to do that either. And practically, it just makes sense. And clearly, we see from the results that those who are on SSRI, there is no impact or no dampening of the effect. So we plan to continue that in phase 3.
Okay, and just finally, for the phase 3, do you plan to only recruit patients on SSRIs or SNRIs already, like you did for phase 2?
Yes.
Okay, awesome. Thank you, guys.
Thank you. Maybe one final question over here.
Hi. Dan Tangone, Oppenheimer. Just a question for Dr. Knudsen. Since the patients in this trial are on background SSRI in the light of this data from the 12 meg and 16 meg, could you talk about how you think about receptor occupancy and particularly the potential for individualized dosing in patients?
Yeah, if I understand you correctly, you're asking about receptor occupancy on SSRIs, and to the best of my knowledge, it hasn't really been examined in people. We haven't certainly done it. It's been done in rodents, and what you see there is a downregulation of 5-HT2A receptors, which is modest. It's not very large. But we also have some interesting data suggesting that a slight downregulation can actually be beneficial for the effects. You have a more pronounced psychedelic experience, which may be sort of counterintuitive, but that's actually what we've seen in a fairly large sample of individuals that we have PET scanned and also given psychedelics. So there are some interesting aspects here that we need to understand even better. But I think actually that could be one of the explanations why those individuals, those patients who are on SSRIs, actually also benefit quite well from the psychedelic interventions. And that's why I think it could be interesting to look at a combination therapy, and we'll see for the phase 3 trial what happens.
Thank you. And just a very quick one for Amir. You mentioned that even half of the effect size seen here would be a win in phase 3. Could you just help us understand some of the variability from this data set that makes you consider those?
Yeah, so it's a small sample size, right? 12 participants per cohort, 3 cohorts, so that's 36. And you're bound to see limited variability in such a small sample size. There were 2 sites. When we go to phase 3, we'll be expanding to multicentric, multinational clinical trials, and that adds to the variability as well. When designing our phase 3, what we have done, so we are in the process of finalizing that protocol right now. What we did was go into the literature and look at what sort of variability has been seen in the past with other clinical trials in depression. So the standard measure for that is a standard deviation of the effect, and we see about 10 to 12 points of standard deviation on the MADRS. We took that into account. We take into account what effect we've seen in our phase 2B. We cut it by half, and that's how conservatively we design our phase 3. So we've taken that into account, and we believe that it will give us the results that we are expecting.
Thank you.
Great. Thanks, everybody. Thanks, all of you, for your engagement this morning. And, of course, thank you to our panelists, Dr. Fava and Dr. Knudsen, for your insights. Thank you very much. We appreciate all of your interest and your support of Cybin, and we look forward to sharing future progress across our programs and a development pipeline. More to come in just the next few weeks. So thank you all very much for attending, and have a wonderful day. Thank you.